Thanks, Sherry, for having me come and chat, because who does not want to talk about the endocrine and the metabolic systems? It's going to be super fun and very riveting, and I will try not to make it as boring as it kind of is, but because there's lots of good information, and it is stuff that you'll think about and see all the time. So it's good to know, but not that great to talk about sometimes. But I don't have any disclosures, obviously, and these are my objectives that you can kind of look over. Hopefully by the end you'll understand the endocrine system and its primary function and some common neonatal pathologies related to some of the diagnostic features for common pathologies of the endocrine system, and we'll talk about management techniques, and we'll talk about some different metabolic disturbances and then their impact on mineral homeostasis. And this is like totally not all encompassing, because we'd have to be here for like the entire day to cover everything. It's kind of like most common, most seen, most talked about scenarios and things. So these are the topics that we're going to cover. Kind of a lot. We'll talk about adrenal disorders, disorders of sexual development, calcium, glucose disorders, magnesium, phosphorus, pituitary, thyroid. We'll talk about infants of diabetic mothers, which we see all the time, and then we'll talk about metabolic bone disease. So I think that the easiest way to think about the endocrine system is to think about it as kind of like a molecular messenger system. So it's elusive, it's troublesome, it causes problems in all different systems of the body and touches all different systems of the body. It's made up of the 9 ductless glands, and all of these function together, and we'll talk about kind of how they function. A lot of them function with kind of like negative feedback, so something happens and then causes a cascade of events, and then goes back and turns that primary function off. Functions include coordination and regulation of metabolism or energy, the internal environment, growth and development, sexual differentiation and reproduction. And like I said, if you kind of think about it being like the hormone system as opposed to the endocrine system, I think that kind of helps keep it a little bit more straight. And just that those hormones are molecular messengers of the endocrine system, and they bind to receptor sites all over the body. This is just a table from like my favorite book, and if you're looking for a good book, it's this NCC book, Core Curriculum for Neonatal Nursing Care. If you don't have it, it's the authors of Verklin and Walden. It's a good book. It's like the best book for like nice, concise, good pathology, good management, good diagnostic techniques, and it's not too wordy. It's a nice book to have, just like a reference book if you're ever interested in a reference book. And you can study for your RNC from it, in case you want to do that. So this lists the endocrine glands for you, and then all of the hormones that each gland produces. And as you can see, you have your hypothalamus, your anterior and your posterior pituitary, and that really makes up the bulk of all of the hormones that your body uses all the time. The adrenals are down at the bottom, your thyroid, pancreas, adrenal medulla. They're all listed for you right there. So just a little thing about hormones. They are the molecular messengers of the endocrine system, and as messengers, they allow for communication between organs, between tissues, and between cells throughout the body. They bind to specific receptors on the surface of target cells to produce a physiologic action. Some circulate in free form throughout the body, and then there are some that are bound to carrier proteins. Most of the hormones are secreted in their biologically active form. However, some have to be converted to their end product. So like insulin is secreted by the pancreas, and it's just already active when it's secreted and you need it. Whereas like thyroxine has to be converted with some enzyme help. So just a little bit of a difference. And then we'll talk about the negative feedback loops that are associated with a lot of these systems. So the negative feedback loop. Just remember that a lot of the hormones are using this negative feedback loop, and it happens between the hypothalamus, the pituitary, and then all the rest of your endocrine glands. So it always kind of starts with CNS input at the top, something that your body needs, the hypothalamus, the pituitary, and then everything else. So all your adrenals, your thyroids, your parathyroids, all of that is underneath your pituitary. So those hypothalamus and pituitary are kind of like the main bosses. You have central nervous input that says the body's lacking in something or there's too much of something else. And then the hypothalamus makes a choice to either release stimulating substances or to release inhibiting substances. And this starts the cascade then that goes to the pituitary, where that releases trophic hormones that then goes to peripheral glands, and then you get the actual end target hormone that your body is actually looking for. When you have a blood concentration then of that hormone that builds up, it negative feedbacks back to the hypothalamus, back to the pituitary, and says, shut off, we have too much, we don't need it anymore. And then it releases inhibiting substances after that to kind of stop everything. Not all endocrine glands work off a negative feedback loop. Like I said, the adrenals and the thyroids are the most common ones, but the pancreas and the parathyroid glands are examples of glands that release a hormone that has just a direct effect on the tissue and doesn't have to go through a negative feedback loop. It just turns on and off directly. The neuroendocrine system acts as a key role in body homeostasis. So being able to function effectively is crucial for a neonate to be able to function and maintain homeostasis outside the womb. So prematurity throws all of this out the window. Systems are underdeveloped, they're early, they don't have enough support from mom for as long as they need to get the system kind of up and running. And so it's dysfunctional. And that's where we see all of the problems that we encounter in our unit. And I'm a visual person, so I like algorithms like this. If you like them, you can look at them. If it's not helpful, you don't have to, but I kind of I won't always touch on them, but I kind of just looking through it systematically in my head. So if you're like me, you can look at it. We're going to start with pituitary disorders, and we're just going to talk about these three, really: hypopituitarism, diabetes insipidus, and then syndrome of inappropriate ADH or SIADH. And there's two different kinds of SIADH. There's a nephrogenic type, and then there's a type associated with acute brain injury. And we see SIADH all the time, but we just don't kind of call it by its name. So it's interesting when you kind of start to learn about it. You're like, oh, I see that all the time, but we just don't call it SIADH. So just a little bit of a blip on the pituitary gland. It has two distinctive structures, the anterior side and the posterior side. During embryology, just like a fun fact, even though they're together, they arise from totally different embryologic tissues. So that's interesting, I think, that they end up coming together, but they're from different embryonic structures. The anterior pituitary releases trophic hormones like growth hormone, ACTH, follicle-stimulating hormone, thyroid-stimulating hormone, luteinizing hormone, and prolactin. And then your posterior pituitary releases oxytocin and antidiuretic hormone. And this is kind of a close-up and a faraway view. It's pretty small. It's kind of tucked back there. It doesn't produce pituitary gland for hypopituitarism, since we'll start with that one. It just doesn't produce normal amounts of some or all of its hormones. So it's not super common. There's a congenital version that's pretty rare. And then you can have an acquired that's just associated with an acute event, shock, a precipitous delivery, really low APGAR scores, a severe infection. So it's just your pituitary either doesn't have the substances, it can't produce the substances, maybe it's lacking enzyme, or mom was exposed to something, or the acquired is just not functioning right at all because of the acute event to the baby. It's often associated with these clinical signs. So a lot of times babies that have midline cranial defects, persistent hypoglycemia that's pretty rangy, they can be mild or it can be pretty severe, prolonged jaundice that just won't go away and there's no direct reason why. or the direct hyperbilirubinemia. We do hormone testing and ultrasound of the brain or an MRI and some genetic testings to find this disease process, and then the treatment is just hormone replacement therapy for the rest of their life. So the congenital one can be associated with optic nerve hypoplasia, which we have seen a couple times in our unit, I think. Or it can be associated with an absent septum pellucidum, which it's not always, because that is not a common, but a finding that we find a lot on MRIs, but can be associated with that. And then some other clinical signs that are kind of non-specific include like poor weight gain, and like we talked about hypoglycemia and jaundice, cholestasis, which would be related to the direct hyperbilirubinemia, kind of that sludge that gets stuck in your liver. You all remember this from patho and nursing school, and I know you're super excited to talk about it. It's the renin-angiotensin-aldosterone system, or sometimes people now abbreviate it RAAS system or RAS system. We'll talk about it a little bit with our disease process more when we get down to the adrenal glands, but I think it's important to kind of go over it now just so you understand it. And I liked this little comic. I think it makes sense to me, and I don't know. I like it. I have another more like scholarly looking graphic on the next slide, but this one makes more sense to my brain. So you have this kidney who senses a decrease in blood pressure, and it releases renin to the juxtaglomerular apparatus. And that, I got to come over here, because it looks really fuzzy on my screen, so I can't really see it. Releases renin. So then renin converts angiotensinogen to angiotensin 1, and this is all in the blood. And then that angiotensin 1 has to make its way up to the lungs, where angiotensin converting enzyme, or ACE, converts it to angiotensin 2, which is a potent vasoconstrictor, and that's that big guy over there. And then angiotensin 2 causes really effective vasoconstriction, resulting in an increased blood pressure. So you have a smaller narrowing of your arterioles, which causes your increase in blood pressure. And it also stimulates the adrenal glands, so those glands there that sit on top of your kidneys, to release aldosterone. And within the kidneys, then, aldosterone, which is another mineralocorticoid, promotes the reabsorption. So reabsorption, if you think about the B in that word, meaning back to the blood, reabsorption of sodium and water, which then increases your blood volume. So you have a narrowing of your arterioles, which increases your pressure, and then you have more volume being back to the blood. You're conserving it, so you have more volume. And then your kidneys back here are happier, and they stop telling the renin to go out. And it's a pretty effective system for low blood pressure, low volume, low sodium, too much potassium, and we'll talk more about that. So this is the more scholarly diagram that you can read all about in your free time. Diabetes insipidus is the next one we're going to talk about. That's a pituitary disorder. It's a posterior pituitary disorder, and it's deficient in the antidiuretic hormone, or vasopressin. Those two names are interchangeable. They're talking about the same thing. Normally, you have your pituitary gland that sends a hormone, ADH, to the kidneys to help control how much urine is made. And in this nephrogenic, or in nephrogenic diabetes insipidus, the kidneys just don't respond to ADH. They just make tons of urine, you have tons of water loss, and they just don't respond to this ADH that's saying, like, hey, stop, like, you don't need to, like, be dumping all this free water. It just is completely oblivious to that. Just keeps making all this urine. 90% of the nephrogenic type is an X-linked, so we find it in males because they don't have that other X to counteract that gene expression on their one X. It's also associated with midline defects, or like a central nervous system injury, hypoxia, or maybe a neoplasm up there somewhere in their brain. And the biggest thing is just this free water loss. So you have hypernatremia because you're losing all your fluids. So it's like a dehydration kind of situation. You have polyuria, you have dilute urine because you have so much of it. You have this vigorous sucking. They often have like vigorous sucking, which is probably their way of like a little bit of expressing thirst, you know, because they have all this free water loss, and then they vomit. They're irritable. Sometimes they'll have a fever. You have to fluid resuscitate carefully because you don't want to overcorrect their sodium too fast because that could result in brain injury. And then there is this drug called desmopressin, which is like a synthetic ADH that you can give to help them regulate a little bit. And if it's usually used and saved for if the baby is just unable to concentrate their urine at all and it's just all this water loss, then you can give this drug and it will help them kind of concentrate their urine a little bit. So syndrome of inappropriate antidiuretic hormone is the exact opposite of diabetes insipidus. It's too much antidiuretic hormone for no reason. So you have this excess ADH secreted in the absence of any hypotension or any like increased serum osmolality. So in diabetes insipidus, as that sodium rises, you would think that the body, and it does, it wants to dilute it. It wants to bring that sodium back down, but the body's just not paying attention. And in this, the ADH is secreted even though you have hypotension, or the ADH is secreted in excess without having hypotension or an increased sodium osmolality. So it's conservation of free water, and it's an inappropriate conservation of free water. Your blood pressure is stable, but your body's conserving all this fluid as if you had an acute event and you were losing blood volume or your blood pressure was unstable. You have hyponatremia, and you have just across the board plasma hypoosmolality. You have inappropriate urine hyperosmolality because it's just dumping things. We have weight gain, edematous, babies, and they are not peeing, so you have oliguria. You do fluid restrict with these babies, and you treat their underlying cause, and you manage their sodium. You can give diuretics to try to encourage free water elimination, but it's kind of a nasty thing. And we see it here and there. So they have normal renal function. I like these little tables. You have normal adrenal, pituitary, and hypothalamic function. You have a normal circulating blood volume, but you just have this excess ADH that's just being dumped out for no reason. Sometimes it could be because you had a central nervous trauma, like you had cerebral trauma, you have encephalitis, hydrocephalus, you have IVH, meningitis. You can see the pulmonary causes down there too. If they're asphyxiated infants, we see this a lot, like in cooling kids. If they have really significant atelectasis. Sometimes continuous positive airway pressure. I didn't really read a lot about that, so I can't really speak to like, I've never seen that, but well, it's on the chart, so we'll mention it. A pneumothorax or pneumonia, RSV, and then just stress can sometimes trigger this. So Osmosis channel on YouTube has tons of really good videos, and they do like videos and drawings with explanations kind of at the same time. They don't have a ton of stuff specific to neonates, but sometimes like SIADH is just, I mean, it happens to adults too, so the patho is there, which is kind of the hard part, and the drawings kind of help figure it out if you're kind of a visual and like an auditory learner at the same time. All right, so we're going to talk about the thyroid gland next. It's the very first endocrine gland to develop around 3 to 4 weeks gestation, and you have thyroid hormone synthesis around 18 weeks. So up until that point, the infant is kind of dependent on mom, but not for very long. It's made up of follicular cells and parafollicular cells that produce calcitonin, which lowers your calcium level. Fluid-containing thyroglobulin is like a hormone precursor. And the follicle cells themselves are the ones that secrete T4 and T3. The functions are iodide uptake and cleavage of thyroglobulin, iodination of thyroid hormones, and conversion of T4 to T3. Many of the tissues in the body can convert T4 to T3 with enzyme help, and T3 is the more active hormone. 70% of T3 and T4 is usually protein bound in that thyroid binding globulin in the plasma, and it's the free T4 that can kind of circulate around and do the jobs that it needs to do. It can cross the capillary boundaries into the tissues that need it. And we measure T4, which is the sum of the bound, and then that's why we also order a free T4, because the measured bound total can be okay, but the free T4 can be low, or vice versa. The free T4 is kind of like a better true measure of like what thyroid status is. And almost all the tissues in the body are affected by the thyroid hormone. You have regulation of normal growth, oxygen consumption, thermogenesis, cardiac output, erythropoiesis, your respiratory drive, your gut motility, metabolism of carbohydrates, proteins, and lipids. And you have to have it for CNS development. And you need to have it for optimal fetus CNS development while the baby is developing inside of mom. It's a pretty important one. And it works off of a negative feedback axis. The hypothalamus, the pituitary, and the thyroid now this time work together. So usually at birth you have this big cold stress event, right? The baby's born, it's wet, we're wiping it off, and then you have that stress give way to like this surge in TSH. T4, because you have TSH saying from the pituitary saying, hey thyroid, we're having this super stressful cold event, I really need some thyroid hormone to help me out. Then you have this T4, T3 increase as a result. Usually T4 will increase to like around a level of like 6.5-ish. And then the TSH will die down after that when it feeds back and says, okay, I have enough thyroid, you can turn off now. We don't need to like stimulate the thyroid anymore. Your TSH will then decline to like less than 20. Preterm babies, numbers are like, no one knows the numbers. No one ever knows the numbers. So that's like about-ish the numbers, but you read 5 textbooks, you probably get a variation within a couple numbers, a couple points here and there. The extreme premature baby that we see a lot, they have a major fall in their T4 over the first like 1 to 2 weeks of life as they experience this stressful event after stressful event after stressful event. They just never really recover. And they almost probably would never really get to baseline for that T4 to even turn off to say, hey, we have enough, because they really probably don't ever get to that time where they have enough thyroid hormones circulating, which is about why we have a lot of our normal newborn screens come back not normal, and their thyroid hormone is low, their T4 is low. The smaller you are, the less likely that you're going to go through this normal transition after birth. So a lot of our babies don't even get there. I just wanted to like briefly touch on some maternal conditions affecting the fetus and the thyroid function of the fetus. So you have Graves' disease, which is an autoimmune disorder. It's usually people are pretty familiar with it. It's an autoimmune disorder that causes hyperthyroidism. So you have these antibodies that mom's body kicks out because it's got an autoimmune component to it, and it just overstimulates the thyroid to like secrete all of this thyroid hormone when it's not really needed. So they just go into like a hyper state, and your immune system just is attacking the thyroid and causing it to make a ton more than you need. So if the mom has Graves' disease and it's poorly controlled, it can lead to an IUGR baby and premature births, and the babies can mimic mom's symptoms, which they often do with lots of disease states, into like a transient hyperthyroid state. They can even have an enlarged thyroid gland, like mom. They could have a goiter that lasts for a little while. They're really irritable. They're hungry. They're tachycardic, really tachycardic. They'll sometimes sweat, and they're really crabby. If you've ever taken care of a kid that has like a transient hyperstate, they're just like inconsolably irritable all the time. If mom has Graves and she's getting treatment and she's well controlled, then all those drugs cross the placenta and can lead to like a transient hypothyroid state for the infant that then will need to just kind of tincture of time itself away. The antibodies, the TSH receptor stimulating antibodies, or those antibodies that are overstimulating the thyroid, they do cross the placenta. So sometimes even moms that do get treatments, let's say have a thyroidectomy, they still have those antibodies present, and they're still kind of going to cross them over to the baby. So sometimes even though mom's been treated, she's not having any problems anymore, she's not on any drugs except for just her Synthroid because she doesn't have a thyroid anymore, the babies can still have kind of a transient hyperstate when they come out just because she still has those antibodies. They just don't have anything to stimulate anymore. The transient hyperstate can last like 3 to 12 weeks. And then we treat them with this. And we have had a couple of kids receive treatment with these iodine preparations. There's 2 of them there. I'm not going to try to pronounce them, but there they are for you. Like an anti-thyroid medication, some sedation if they're really crazy, and then like a propranolol or like a beta-adrenergic blocker to like bring their heart rate down if they're super tachycardic. Maternal hypothyroidism, and we just kind of talked about that, like second to surgical intervention after an autoimmune disorder, or if mom has like an iodine deficiency, then that can also affect the baby too. This baby's pretty dependent on mom's adequate supply of iodine. So if mom's deficient in it, then they're not going to create their thyroid hormone and can result in kind of a transient like hypo state. Leading on to hypothyroidism, which is defined as like a significant decrease in or the absence of thyroid function, and it's usually present at birth. It can lead to pretty severe developmental delays, so we try, if it's a congenital version versus the transient, we try to treat within 2 weeks, especially if that TSH is really, really elevated. So the incidence is there for you, 1 in about 3,000 to 4,000 kids. And you have this either an absent hypoplastic or ectopic thyroid gland. So you have your hypothalamus telling your pituitary to spit out TSH, and it's spitting out TSH and it's spitting out TSH, but your thyroid hormone level, your free T4, is never rising because you don't have a thyroid, it's hypoplastic, or it's ectopic. It's not in the right spot. So that's a congenital version, and it's permanent, and they'll need lifelong hormones to help them grow. And this is the one that leads to really severe neurodevelopment effects if it's not treated, because it's never going to fix itself. It's never going to be enough thyroid hormone. There is a familial dyshormonogenesis version that's like 10 to 20% of the congenital version, and this is not, the thyroid is there, but there's like a thyroid hormone metabolism defect. So it's like almost like an inborn error of metabolism a little bit. There's like an enzyme deficiency somewhere or a substrate deficiency where they just can't even make the hormones. They have the glands, but the hormones just can't produce the hormones. So that's about 10 to 20% of the congenital version. Sometimes there's a thyroid binding globulin deficiency, which is another X-linked. It's found more commonly in males. And then we kind of talked about sometimes they just have hormone resistance or something like that. So transient can be prenatally acquired if mom was exposed to drugs that had some effect on thyroid production, or if there were some like maternal autoimmune thyroid receptor blocking antibodies, which moms can sometimes have too. They're just blocking and transferring across the placenta and just blocking the infant from making their own thyroid hormone. That can also be kind of a reason why they're hypo. For the prenatally acquired versions, there is a Euthyroid 6 syndrome that we see a lot. This is when it's kind of our older babies that we see it in, where they have immature lungs or they have infections and they have some inflammation going on, which can deactivate that T3. And it's kind of like they're just sick and they just can't keep up. So they have this like transient hypothyroid state. And so I've even seen babies that, they're, 4 or 5 months old and they're chronically ill and they're just sick kids and they end up needing Synthroid or something like that just to get them like a little boost because they just cannot make that thyroid hormone. They have too much inflammation. It's deactivating their T3 and they can't ever get to that free T4 level that they need. Usually with the Euthyroid 6 syndrome, they have low T4, but their TSH is fairly normal, so it kind of helps differentiate it from the congenital, which is always going to have a super high TSH and a low T4. The transient, sometimes the TSH will be more normal and the T4 will just be low, and so that kind of can help decide like which one you're dealing with. And prematurity is over in the transient column for sure. Again, they just have low levels of thyroid binding globulin, which transports that thyroid hormone through the body. They don't have a lot of maternal contribution to their thyroid hormone stores in the beginning, like before that 18 weeks and 18 to 20 weeks when they kind of take over the production of it. They have insufficient enteral or parenteral iodine intake, so they just can't make it. And usually we just monitor every 2 weeks and just check their levels as long as their T4 is not too low and their TSH stays more normal-ish, you know. Because if their T4 drops too low, then their TSH should rise, right, and become abnormal. And then if that, you know, if it's a trend where we see like, oh, your TSH is, you know, it's just kind of in the median, we'll watch it, but it's like inching up and their T4 is inching down, then that might be the decision, like, okay, let's treat this kid just for a while, even if it's just transient. Sorry, this is really small, but there's a lot of to put under the clinical presentation. So they can have a large open posterior fontanelle, and the clinical presentation is more with the congenital version of it. So they can have like a big open fontanelle. Usually they have a bigger birth weight or they're older, kind of like coarse, kind of sharper features. Some delayed bone age. They can have an umbilical hernia. They can have a goiter, thick skin, poor perfusion. I mean, kind of think about like an adult that has hyperthyroidism. They're cold all the time. They're gaining weight. They don't want to do anything. They feel lethargic. So however that's going to manifest in your infant, they're going to be sleepy. They don't want to eat. Maybe they have prolonged hyperbilirubinemia because their liver's not working very well. They have some edema. And then they can have some midline defects as well and some bradycardia. So our newborn screen is just a screen, so we're just screening. If it comes back abnormal, we always send our diagnostic tests. So we're going to send like a free T4, we're going to send for a TSH. We can send thyroid binding globulin levels if we want. We can do the maternal anti-thyroid antibody testing to see if there's some antibodies on board that mom's been transferring to baby to see if it's more of a transient situation. We can do a Doppler ultrasound of the neck. We can do bone age x-rays of the knees and the foot to see if there's like a delay in bone ossification, which gives us an indication of like how long has it been going on, how long have they been without. And that's probably for a kid that's like presents us to the pediatrician and then now is going to get worked up. So not really maybe something we would see like in the NICU. Early identification, like we talked about in treatment, is important, and we treat with this levothyroxine, or Synthroid is the brand name. T4 levels can normalize in like 1 to 2 weeks, and TSH can take a little longer for that to kind of negative feedback loop can kind of kick down a little bit, kick that TSH level down. And then we usually, when they're on that Synthroid, we usually check every 2 weeks until they're really stable, and then maybe a little bit longer out than that. So. Congenital hypothyroidism remains still the most preventable cause of mental retardation in infants. So which sounds kind of crazy because I don't hear about congenital hypothyroidism very often, but it's still the #1 cause for mental retardation for infants. So it's worth saying, and delaying treatment for weeks after birth can result in a drop in IQ points by several points every week that treatment is delayed. So it's a big deal. Check your newborn screens. This is a nice summary of low thyroid states in the newborn infant, and it is a table that I think, again, is from that NCC book. It's just, it's confusing, like what's low, what's high, what's in all the different conditions that can cause the low and the high. So I put the red circles around the ones that are like the most common ones that we see. So T4 low, TSH elevated. That's going to be your congenital state. And if it's bad enough, it can be your transient state. So if it's gone on long enough and we've like let it go, we're just catching it, or it's a kid that's been in the unit forever, and it's like let's check a thyroid level, and his TSH is sky high, or a 30-day newborn screen, it's not really been on our radar, and then the TSH is 60, so something like that. And then the low T4 and the TSH is normal. That's a lot what we see in prematurity. So we don't always treat our premature infants when they have a low free T4. Sometimes we'll just watch it, kind of see what they do, see how they're growing. So kind of would like beg the question, like what would happen if we just treated it since it's so important to all of our tissues, but I'm sure that there's some literature or study out there somewhere that says it'll probably be detrimental some way or how, and that's why we just wait it out. We're not going to go over all this, but it's just another way for you to look at it if you want to, and it's from the American Academy of Pediatrics and the American Thyroid Association. It's from 2006, and it's just an update on newborn screening and therapy for congenital hyperthyroidism. So when you get these abnormals here on this column here, these abnormals here, then what do you do after that? And when do you treat and when do you don't? So it's kind of a nice little algorithm that you can look at depending on like what you're going to do for management. Watch your weight, go ahead and treat. Adrenal disorders. This is a good one. Your adrenal glands, like we talked about, are located on the top of your kidneys. They're super vascular, and they have an inner medulla and an outer cortex. They're mesodermal in origin, if you want to know the embryology behind it. Nicole, I know you do. Your cortex, so your outer layer, has 3 classes of steroids. They all come from cholesterol. You have your glucocorticoids, and your main one is cortisol. You have your mineralocorticoids, main one being aldosterone, and then you have your androgens, or your sex hormones. And then your medulla is linked to your sympathetic nervous system, and it gives you again, produced a little bit of a different embryologic tissue or origin, your neural ectodermal origin. And it produces all your catecholamines and stores them for you. So your epinephrine, your norepinephrine, and your dopamine. Going back to the cortex, that cortisol is your primary glucocorticoid and has a huge role in glucose homeostasis. So it regulates development, it regulates growth, your inflammatory responses, your cardiovascular functions, and then like response to stress is the big one. And that's kind of where we see like our preterm infants like suffer, is they just can't mount the stress response that we talk about that they need for like infections or surgeries or anything like that. Cortisol is regulated by your ACTH, so it works with a negative feedback loop again. And we are going to talk about that more, but it's that kind of the smaller square all the way to the left on that diagram that talks about the negative feedback loop between the hypothalamus, the pituitary, and the adrenals. It's released in response to stress, low blood sugar, surgery, extreme heat or cold, decreased oxygen consumption, infection, injury, acidosis, anything like that. Until about 30 weeks, the fetus gets most of their cortisol from their mom. It just readily crosses the placenta, and the maternal cortisol is pretty rapidly metabolized by the placenta to protect the infant from an overabundance of it, which is kind of cool. And then in the last 10 weeks of gestational development, you kind of get a surge in the infant, and they think that this is just helpful to like lung development and getting the baby ready for the extrauterine environment. Aldosterone we'll talk just a little bit about. So that, if you remember, was on the very end of that renin-angiotensin cascade. So that tells your body to conserve salt and then conserve water at the same time, so you get an increase in your blood volume. So if you have any drop in intravascular volume, or you have a rise in sodium concentration, or a rise in potassium, it's going to tell your aldosterone is going to kick in at the very end of that renin-angiotensin converting cascade to then aldosterone to tell your body, hey, we need more fluid because we have too much salt, we have too much potassium, or we don't have enough blood volume. Adrenals of note are one of the 3 organs that are preserved in states of hypoxia, along with your brain and your heart. So sometimes people will just say kidneys, like brain, heart, and kidneys. It's not really your kidneys. Your kidneys usually take a hit. And I even took care of a baby. It was really sad, who had a bad asphyxiation event, a preterm baby, and ended up coming out of it okay, did all right, but then ended up dying of kidney failure because his kidneys had taken such a hit during the hypoxic event preceding his birth. So your adrenals, because it has all these important hormones, will be preserved with your brain and your heart, but your kidneys usually take a hit if you're hypoxic for too long. And then androgens, are your sex hormones, and they're the third class of steroids there from your cortex. Also regulated by ACTH, and they are substrates that then at the peripheral tissue level convert to testosterone and dihydrotestosterone, which for boys is important. For girls too, but for boys especially, as you know. Just another table that I liked. If you're into tables, you can see the hormone, what it's secreted by, and then the function of it. So if you like to kind of look at it in a different way, that's good. These are the states that we're going to talk about related to adrenal disorders. We'll talk about transient adrenocorticoid insufficiency of prematurity, which we see all the time and treat all the time. Adrenal hemorrhage, which is not as commonly seen. And then congenital adrenal hyperplasia, which if you've been in the NICU for a while, has anybody ever taken care of a baby with congenital adrenal hyperplasia? We've had a couple at Methodist, so it's been a little while. Most common cause of female virilization is this one, so we'll talk more about it. Transient adrenocorticoid insufficiency at prematurity. This is the one that we see all the time. So we get like a big surge in cortisol at birth, right? Because birth is like a super stressful event, and the baby's really stressed out, and then it has kind of a nadir at about 4 days of life as that cortisol kind of starts to fall. You have a cortisol precursor. It's an enzyme, and we're just going to call it by its abbreviated name, 17-OHP, is high because it's like helping make that cortisol level. And then it also declines like 12 to 24 hours after birth in like a normal state. Remember that a lot of our preterm babies, you have moms that are getting steroids for lung development, but are also blunting their own steroid production. So steroids cross the placenta like anything. So these moms have gotten a round of steroids. Maybe it's their second round of steroids. Maybe this is a rescue dose now of steroids. And so that's been 3 separate times that this infant's now been exposed to steroids, and it's blunting their own production of their glucocorticoids, steroids. And so sometimes that can result in like a transient inability to kind of mount this stress response all of a sudden when that umbilical cord is cut and they're not attached to mom anymore. And it's just that the adrenal gland can't maintain cortisol homeostasis in like the early days of life. It's this transient insufficiency of prematurity obviously is in preterm infants. They have peripheral collapse and shock symptoms. They have hypotension, and I bolded these because how many times have you seen a baby who stops peeing? They hang on to fluid. They don't pee very well. Obviously, they have hypernatremia, and then they have hyperkalemia, and you're like, oh my gosh, this kid is acidotic, it's totally sick. And really, it just probably needs a little bit of hydrocortisone because it's probably having an adrenal crisis. And we treat a lot of our kids. It's refractory hypotension is really kind of like the thing here, especially that I see with the docs that like kind of kicks them into that hydrocortisone. You got your dopamine going. Maybe you did your dobutamine. This you have, this 900 grammer that's still their blood pressure is kind of in the toilet. Their sodium's in the toilet. You've done all the things with the fluids, and they're like, just start hydrocortisone. And then all of a sudden, magically, it's like fixed in like 12 hours because it just needed some adrenal support. There's the feedback control of glucocorticoid synthesis. If you want to like go through that systematically, it's kind of a nice like way to think about it from start to finish. And then ACTH challenge with the question mark down at the very bottom. Some physicians you might run into at different institutions, if you ever go anywhere else, will say like, oh, we should do an ACTH challenge just before we start the kid on hydrocortisone. It's really a debatable topic because it requires blood, like everything. Like it's always a risk balance situation. Like, is it really worth the blood and the time that it's going to take to like give this baby ACTH, see what the cortisol does? What's a normal cortisol for a 900 gram infant? No one really knows. So it's not done a lot, but we do it on older babies just to kind of see like what's their tolerance now. Like, can they handle stressful events? Like kind of gauging like what their body's ability is to mount that stress response. If we give them this ACTH, like they are having a stressful response, does their cortisol increase? So we do it to older kids just to kind of see like where are they at with their own responses, as opposed to like should we treat them type of thing. Questions? Cool. Adrenal hemorrhage isn't as common. 1.7 to 2 per 1,000 live births. That seems kind of like a weird number. Yeah, I typed that wrong. I've never seen this. Has anybody seen this? Me either. This happens a lot in big babies that have a traumatic delivery or a difficult delivery, and they're like pulling and pushing, and somebody's pushing on mom or whatever. So you have larger adrenals in bigger infants. If the baby's already LGA, they're already set up as a macrosomic infant for a difficult delivery. Maybe they're breech and they're going to come out vaginally anyways. They have some perinatal asphyxiation. If they're sepsics, if they have like some coagulation disorders, can all be contributing factors to a hemorrhage in their adrenal glands. Usually they're pretty pale, and it can range from like subtle, you would never really know it was there, it kind of resolves on its own, to then like this emergency of like now we're kind of shock and we have like significant hypotension and we have a bleeding adrenal gland. So all of the things in there that are now supposed to help us with this stressful event are like swimming in blood, so they can't really do anything. So sometimes they'll have a flank abdominal mass if you have like unexplained anemia or jaundice. And then there was an article that I read not too long ago actually that had the only symptom in this kid was it had a bruised scrotum, and no one could figure it out. They were like, is it a hydrocele? No. Is it, a testicular torsion? No. And it was just a bruising scrotum, and it was because he had an abdominal or an adrenal hemorrhage. Interesting. If you have a flank mass, just of a pearl is that it could be a neuroblastoma and not. That's kind of the differential diagnosis between with the flank mass, neuroblastoma, most common neonatal malignancy, versus adrenal hemorrhage. Abdominal ultrasound will help you diagnose this state, and then just conservative management with surgical intervention only if necessary. It usually resolves in 4 to 16 weeks on its own. You just support with fluids, you support with meds to kind of like get them over the hump. So medically manage if you can. All right, are you ready? This is kind of a long one, and it's like has a lot of like pieces. But congenital adrenal hyperplasia. So the incidence is there for you: 5,000, 1 in 5,000 to 1 in 15,000. Like every piece of literature has a different incidence rate on it. So there is the range for you. Most common form of female ambiguous genitalia. And I meant to take this verbiage out because we're really, like, if that is like, no verbiage anymore. Like, you're not supposed to talk about ambiguous genitalia. It's like, you're not supposed to, like, use pronouns when you're talking about your children, like, all of that. It's disorders of sexual development to be, like, kosher, and that's how you're supposed to talk about it. So scratch that because it's not really what you're supposed to say. But most common form of female virilization is really what that should say. It's a group, actually, of autosomal recessive genetic disorders, and it all results from a deficient activity of one of the enzymes to synthesize cortisol from cholesterol. So you just have a deficiency in an enzyme, and so you do not have the end result of cortisol, and you have a buildup of these androgens. And we'll get more into that, but that's kind of like the, in a nutshell, version of like what it is. And there's tons of different gene mutations that go along with it, like over 127. The most common is this mutation of the 21 hydroxylase gene, which is what most literature will talk about if you read about it. So that's what we're going to talk about today. You have a lack of this 21 OHD enzyme. And so you cannot convert progesterone to which first is cholesterol, then it goes through a process, some phosphorylation chemistry problem. Then you have progesterone, then you have cortisol, then you have aldosterone. And so you do not have this enzyme to help you do that. And so you don't have cortisol, can't mount a stress response, and you don't have aldosterone. And you have some crossover into your sex hormone androgen cascade pathways that then just bumps up these androgens, and these female babies result with some virilization of their genitalia. Let's see, the hyperplasia part of it, I just wanted to talk about because I think a lot in like titles. So congenital is acquired at birth. It's a genetic disorder. Adrenal is where it is, right? It's in the adrenal gland. And then hyperplasia, because you have this negative feedback loop again with the hypothalamus and pituitary for your body that's not having cortisol, then it's telling the pituitary, like, please give me some ACTH, please give me some cortisol, like I'm really hurting here for some cortisol. And then you have this like pumping out of ACTH, and you have overstimulation pretty much of just the adrenal gland, and it just results in this like bulky hyperplastic gland then, because it's just been overstimulated and overstimulated. It doesn't have the enzyme to do what you want it to do, but the ACTH is still like beating on it, like we need the cortisol, and it's just like, I can't. Pretty sure that's what it says. So I like this graphic. It's from my favorite book. You should all get it. If I had a bunch of money and I won the lottery, I'd buy you all a copy. It just, again, you have no cortisol, so you have this increase in ACTH, you have adrenal hyperplasia. You have excess androgens causing virilization of females and males, which is harder to tell in males because they are already developed as males. You don't have aldosterone, so think about that renin-angiotensin aldosterone cascade. So you don't have aldosterone, so you do not have this hormone that says, hey, we need to conserve sodium, hey, we need to conserve water. And so you have salt wasting, and you have hypotension, and you have all kinds of problems that result in like shock and terrible things. And then you have this excess of the 17-OHP. So this is a precursor to cortisol. And because you're never going and converting all the way to cortisol, you have this enzyme that just builds up and builds up and builds up because it's not going anywhere because you're never making cortisol, and it's a cortisol precursor. But it can't do anything unless the 21-OHD does its job first. So you have an excess of it, and it builds up, and it kind of crosses over this way, like into your androgen pathway down there. And you have this overproduction of androgens that then results in the little girls. And I have a picture on the next slide. It's kind of like, woo, in your face, but it's just like what it looks like with these little girls have this disease state. So they just have like a virilization. So, I mean, you would look at that and you kind of like would maybe be like, you just say like something's not right, you know? So, and Prater stages it in different stages. So like going from mild to then severe. But you wouldn't look at that if you knew it was a little girl and say like, that's just quite not right. Something's probably going on here. And so girls, it gets caught a lot earlier. Males, male infants often, if they don't have significant salt wasting, you know, if they kind of like have a little bit of aldosterone production, like maybe they have like deficient hormone but not, or enzyme, not absent enzyme, they have like a little bit, because there's like all the spectrum of different like severities of everything, right? So they will show up in the ER though with like vomiting and weight loss, lethargy, dehydration, low sodium, high potassium, hypoglycemia, hypovolemia, and shock, because they just have no aldosterone, so they have all this salt wasting and water loss. They just don't hang on to anything. And then if it progresses and isn't caught, then it can lead to shock and death. Sorry, I don't have the mortality statistics for you. I can get them if you would like. But yeah, usually with your baby, your girl babies in units or like in the newborn nursery, they're caught just because of their abnormal genitalia appearance. So their phenotype doesn't match what you know they should look like as girls. Shock, peripheral collapse, poor feeding, failure to thrive, hyponatremia, hyperchloremia. So they have like a salt wasting side to it too, but you just think about that a little bit after the other side of it. For diagnosis, you send lots of labs. So you will send karyotype in fish probably. Your fish for aneuploidy, so something other than those chromosomes that you're supposed to have. You will send for a 17-OHP because this is a substrate. You can't test for the 21-OHD because that's what you're deficient in, so you have to test for the 17-OHP, that cortisol precursor that you have this elevated level of. And it will be pretty level. I think over here it even has on this table values for you, which is pretty good. So what it should be and then what's abnormal. And it's significantly elevated, 400, greater than 500 in term infants. You'll send, you can do an ACTH stim test. You'll send cortisol levels, aldosterone. The DHEA is on your androgen side, kind of the precursors. It is one of your androgen precursor to your testosterone. Urine electrolytes, you'll get a glucose because we get a glucose with everything. And they'll be hypoglycemic. And you can see some metabolic acidosis too in these babies. Usually we'll do an ultrasound of the pelvis just to visualize the adrenal glands. You can see the hyperplasia a little bit, and just to see, does this baby have a uterus? If it's a girl, and ovaries. We'll treat with hydrocortisone, and then this 9A fludrocortisone, which is a mineralocorticoid, and then they also will need quite a bit of salt substitution, or supplementation to get them through. And as you can imagine, it is a lifelong struggle. So you will have a genetic counselor working with these patients. You'll have a PD endocrinologist, lots of education on parents. Gender rearing for girls is a topic that you could spend a whole day talking about. How are you going to raise this baby? Or, it gets messy. So a multidisciplinary team approach is crucial. Lots of support for parents. They don't often catch this prenatally, so it's usually postnatally that you see it. And then lifelong medical management, especially in cases of stress or illness, they will need even more steroid support if they have a stressful event in their life or they're sick. So this is kind of the drugs that we use to treat it and kind of the mechanism, action, indication, and then the doses there if you're interested in that. Questions about this? That wasn't so bad, right? Does that make sense? Sort of? Okay. Ish. I threw this in there, and I actually don't think I have it on the main topic of areas that we're talking about with adrenal disorders, but iatrogenic adrenal insufficiency, a transient state, and we see this all the time in our big-term chronic lung kid babies, right? They can't come off their steroid. So we had glucocorticoid therapy for them for a variety of reasons, mostly related to their inability to come off their ventilatory support. So we're offering dark horses and prednisolone doses, and we're offering all these steroids to try to get their lungs to develop so they can leave the hospital and go home and live fruitful lives, hopefully. But they have this adrenal insufficiency because we give them exogenous steroids, and then we're blunting their own body's ability to create these steroids, right? Because if we give them steroids, their body's like, oh, I don't need to do any work. They're just going to give it to me. So then you have this blunted effect, which is why you have to wean slowly and taper your dosing off with steroids, which I'm sure you're all aware of. Usually treatment, which this was kind of a surprise to me, of even I feel like greater than 14 days is kind of a short number. I'm thinking oh, they'll have to be months or weeks, but that's 2 weeks. I mean, we do burst doses of Dex sometimes, 3 burst doses of Dex sometimes, or just even hydrocortisone. How long are our kids on hydrocortisone? So it doesn't have to be dexamethasone that does this. It can be any steroid that causes this adrenal insufficiency. And so they have an inability to mount a stress response again. So now they need a circumcision outside, or they need a hernia repair outside the NICU, or they need to have another eye exam, 6-month eye exam. All those little stressful events outside of the NICU can then cause them to have a little bit of adrenal insufficiency. And I'm sure there's a spectrum of how that manifests at home. But some kids that are on it for kids the chronic kids that have been in our unit, HIPAA, if you say it 3 times, it doesn't really happen. Don't you know that? So yes, you all know who I'm talking about. Those kids are on steroids forever, and they will probably need lifelong, at least in the first couple years, of burst doses if they have a super stressful event or an illness or something. So the way you do it is you decrease that glucocorticoid by half every several days until you reach a physiologic replacement dose, which is 10 milligrams per meter squared per day. I know our dosing is in milligrams, but if you if you look at the notes, the doc's notes, they'll talk about in milligrams per meter squared per day, which is just a little bit of like a more specific dosing. And that's a pretty low dose. That's kind of like a physiologic dose, and like 30 milligrams per meter squared is more of a stress dose, or what they might need if they have surgery or they get sick or something like that. And then kind of once you reach that physiologic state, you're supposed to kind of decrease by 20% every 4 to 5 days. I didn't clear this through Josh, so maybe this might not be exactly what we do here. I would have to ask Josh, but I don't think he would like too much debate that with me. He probably would, but. And then sometimes you can have adrenal suppression for greater than 6 months. Even after completely discontinuing, you can still need some, you have some adrenal suppression after that. So interesting. Here's just a table with some different causes of adrenal insufficiency in the newborn. We've talked about a lot of them, but just to kind of like put it all together on a table, just kind of a recap of all of them. And then, some signs and symptoms. Just another table that I like because it kind of puts it all together. You could talk about it, and I'm probably all over the place a little bit, but just a table to kind of put it in as like what the hormone, when you have a deficiency in that, what does it look like? When you have an excess in that hormone, what does it look like? So you can kind of think a little systematically about it. It's kind of nice. All right. This will also require another deep breath. So we're going to talk about disorders of sexual development. I think the easiest way to think about this is that you have a discrepancy or an incongruency in one of the 3 stages or all of the 3 stages here. So you have this fertilization chromosomal sex, so that's like a cellular level, so you have a discrepancy at that level, or your gonadal differentiation as you're developing it through your embryonic stages while you're inside of mom, or you have a problem now with your differentiation of phenotypic sex. So this is what you look like. Your phenotype is what you see on the outside. So of either internal or external organs. So it's like what you can look at. Fertilization is directed by your sperm, and then the next 2 steps, so your gonadal differentiation and then your differentiation of phenotypic sex, is driven by your genes. Everybody starts out as girls, and depending on if you have a Y in there to give you some gene impression, then you can differentiate as a boy, but everybody starts out as girls, as note. And by 7 weeks gestation, the fetus has these 2 primitive ducts, these Müllerian ducts for females and Wolffian ducts for males. They're present testes by 7 weeks. And then in the male ducts, these Wolffian ducts, you have these Sertoli cells with this Müllerian inhibiting factor, and these Leydig cells, which has androgen secreting cells that then give you the testosterone, they're kind of that end peripheral tissue that your androgens work on then to give you that testosterone. And if you have those 2, then you get to be a male. And if you don't have any testosterone, then those Wolffian ducts just regress by 11 weeks and the infant develops as a female. That's like the most watered down version of it ever. I mean, if you like read anything about it, it's so complicated. It's a wonder anybody actually turns out normal, boy or girl. It's a lot of different steps. There's just so many areas of places for things to get caught up and messed up. So everyone starts out with the same primitive external genitalia. We're identical in the very beginning, and then 8 to 14 weeks, male differentiation starts with the influence of those 2 substances. That DHT is a metabolite that's produced from the testosterone and influenced by that enzyme, that DHT has a 10 times the binding affinity of testosterone to androgen receptors in the genital tissues. And so in the absence of that, DHT feminization occurs like we talked about, and that's complete by 11 weeks. There's lots and lots of different disorders of sexual development. These are some, and I kind of categorize them because I think in categories it helps me keep things straight. Like I said, there's just an incongruence with these disorders of sexual development between the molecular, the gonadal, and the phenotypic sex. So something doesn't match up. Often it's a failure in the steps to become a male, or you have a fetus that's XX, so a female fetus that's been exposed prenatally to some androgens during developing, that then will result in her being virilized. So it's either one of the, either it's kind of a boy gone wrong or a girl that's been had like this outside influence that's caused her issues. Disorders of chromosomal sex, so everyone should have XY or XX, and these Turner syndrome, which is a pretty common genetic disorder, they have 1X. So I just put a little bit about the phenotype there, what they look like. They can have this kind of shield chest. This lymphedema is pretty like something to hang your hat on. So it's just really puffy ankles and wrists, like really puffy tops of their feet, kind of wide space nipples, low set ears. They can have like a really high arched palate, a low hairline. They can have kind of this like neck. It's a little bit different than like trisomy 21, but kind of this extra neck skin in the back. Short stature, and they will develop mentally fine, but they are virilized, so they will never be able to have children. I mean, maybe I shouldn't say never. They can adopt and all that, but they won't be able to bear their own children. And then if you are looking at this PowerPoint, you can click on that link there, and it should be a live link that takes you to like more information about Turner syndrome. I should show it?
Like, no, there's like an investigation show.
Oh.
You know what I'm talking about?
No.
Anyway, there's an actress that has.
I was like, you want a picture? I can Google one really quick. And then we're not going to go into all of these. So I just listed some for you there that you can look at. Disorders of phenotypic sex. So that's where that congenital adrenal hyperplasia comes in. Androgen insensitivity syndrome for boys, like complete androgen insensitivity syndrome. Lots of different, that enzyme, that 5-alpha reductase, remember that's the enzyme that helps with that DHT, that potent testosterone. So if they don't have that, if they have deficiency in that, they have deficiency in testosterone. So there's all kinds of different ones. You can read all about them if you want to. There's just a lot to go into. I wanted to touch on them, but not go into like detail about them because I'm in no way, shape, or form an expert, and it's very complicated. It will take up too much time. Another table, too, kind of the etiology of male or female genital phenotype inconsistent with the genotype. So the genotype is like their cells and their DNA, and the phenotype is what you see on the outside. So, you know, the disorder and then kind of like the etiology behind it. For your reading pleasure. Management, I just wanted to say a little bit about this. This consensus statement on DSD management down here is from 2006, and it's from the Lawson-Wilkins Pediatric Society and the European Society for Pediatrics Endocrinology, and it was like the first consensus statement guidelines that were put out by these two groups on like how do we approach these infants? How do we talk about these infants with the family? What kind of treatment do they need? How do we get them set up with this like extensive, gigantic multidisciplinary team that they're going to need to like now carry them through their life? And so it's, I mean, you're like not on an island with these kids. You just, it's a nice statement as a provider to kind of go through and like look at like what are the steps we need to take and be able to kind of talk to the parents. And in delivery room tact, like sometimes this is known about ahead of time, sometimes it's not. So to try to avoid using her or him or, you know, oh my gosh, what's the matter with that? You know, like, I mean, no one would do that, but, you know, somebody that we all know would do that. So just to, like, be tactful and be comfortable talking to the parents about it, you know. They just want they want answers, they want support. It's a pretty stressful thing, and how they're going to raise them. We're going to talk about the pancreas. Sugarland, Texas. That's funny, right? Mm-hmm. All right, tough crowd. So we're going to talk about glucose disorders in infants of diabetic mothers. We're also going to talk about neonatal diabetes mellitus, which I forgot a word there, and congenital hyperinsulinemia and hyperglycemia. We're going to talk about all of that. So the pancreas is an endocrine and an exocrine gland. It's responsible for hormone regulation and blood glucose levels, and it's regulated by these cluster cells within the pancreas called these islets of Langerhans. You have alpha cells, beta cells, and delta cells. Fetal insulin is found around 8 to 10 weeks. Insulin does not cross the placenta, so the fetus has to produce it on its own, or it will not survive. Glucose is like readily crosses the placenta, as we know, but insulin does not, so they have to make their own insulin. And they're usually really good about it, and they're very good about managing mom's glucose load regardless of what it is. I mean, they'll take it in, right? I mean, doesn't end well for the baby, but they're pretty good at managing it in the moment. And remember that insulin is a growth hormone. So for a while, that was like a hard concept for me, and that was like, you think of infants of diabetic mother, and you're like, oh, it's the sugar that's like making the baby so big and like so detrimental to the baby, but it's not the sugar, it's the baby's insulin as a result of the glucose load that they're experiencing from mom. That insulin is a growth hormone. So insulin is like it helps that glucose get into the cell. Glucose is the primary energy source for almost every cell in your body. And so you have to have insulin, though, to get that glucose into the cell. So they have to make all of this insulin, and they grow as the cells use this glucose as energy. It's like using this energy, it's growing, it's getting bigger, and then they end up with these like gigantic babies because they've had all this insulin on board. So it's the sugar, but it's the insulin that causes the problems, like what you see, and the issues with the organ development and then function afterwards after they come out. Talked about that it's present at 8 to 10 weeks. Insulin helps with the uptake of glucose by muscle and adipose tissue. So you have that big glucose load that mom has, or you have a normal glucose load, and then you have the umbilical cord that's cut, and then the infant's glucose and insulin levels both drop, right? And that's like a whole nother discussion, like how low do you let them drop, and what's an okay low level. But then as those glucose and insulin levels drop, then the baby's glucagon and epinephrine kind of goes up, and then their glucose production starts, and so they can maintain a glucose level that is okay for their brain and okay for their body. I'm not going to give a number because there's no magic number that exists in any documented literature. Depending on how old the baby is, should it be 40, should it be 50, should it be 60, should it be 50? Should it be 70? Sometimes some endocrinologists are like 70. It should be 70. It's never going to be 70. It's crazy. Good luck. And then this is just a little table too. We'll talk about cell type, hormones secreted, effect, and then the mechanism. And we will talk a little bit about some of this lingo here in just a minute. Actually, let's just do that now. Let's do that and then come back. So I just wanted to throw in a little bit of like glucose homeostasis terminology, because I think you read and you hear it a lot, and sometimes, at least for me, a review on like what everything means is always a good thing. So you have these two major carbohydrates for energy. You have glucose, which is a monosaccharide, and glycogen, which is a polysaccharide that's stored in the liver. Glycogenolysis is the breakdown of glycogen. Gluconeogenesis. See, you have to say it right. Gluconeogenesis is the formation of glucose from non-carb sources. So this is when you don't have enough glucose available, but you need glucose, so your body starts breaking down your fat and starts breaking down your protein instead. And you get these ketones then with that, and free fatty acids. And then glycogenesis is the making of glycogen from glucose. So you have extra, and so then your body makes extra and stores it in the liver for when you're fasting. Lipolysis, sorry, I have to say it right. The release of free fatty acids from stores of triglycerides can also help bump your glucose up. And then ketogenesis is the oxidation of free fatty acids to produce ketones, which our newborn babies do this a lot, because then they can use these ketones for energy while they're fasting and their mom's milk is coming in, if they're kind of a healthy, normal term infant. Okay. The first disorder we're going to talk about is neonatal diabetes mellitus, and it is a pretty rare disease. I have found an incident rate of 1 in 100,000 to up to 1 in 5 million. So take your pick on that. incidence rate, but it's pretty rare. I think we've had one kid, right? You know who I'm talking about? One kid in the unit that had this. It was pretty interesting. And it took a little while to like get there with him with this diagnosis, which it often does because it's not on the forefront of everybody's minds. It can be transient. About half of the cases are transient, and then the rest are like a congenital permanent disorder. And it's just a fail of the pancreas to release sufficient insulin in response to high blood glucose. So it's just like adults. It's just a failure, like type 1. It's a failure of the pancreas. Commonly, these kids are pretty IUGR because they didn't have enough insulin in utero to grow themselves. So they're usually really small and kind of puny and scrawny. And he was, right? He was pretty little, I want to say. And they end up with ketoacidosis. So just like a kid that comes into the ER that then gets diagnosed with type 1 diabetes, they come in ketoacidosis. They come in when they don't have enough insulin to manage their glucose load. And because they don't have enough insulin, they can't get the glucose that they've taken into their cells. So they have this high blood glucose load. They can't get glucose into their cells, so their cells are starving. They like want the glucose and they can't get in. So then they start to break down their acids, which then results in this ketoacidosis. They break down their fats to try to offer the cells something for energy to function. And then when your body breaks down those fat, it just results in those ketones, kind of a buildup in your bloodstream, which can be detrimental to the brain. The older the baby is, too, especially. Newborns handle ketones a lot better than older children or toddlers or adults, for that matter. Talked a little bit about the clinical manifestations. If you have a high glucose load, remember glucose spills into the urine, and what follows glucose in the urine? Water. So you're going to have like glucosuria, you're going to have like spilling glucose, polyuria, you're going to have lots of urine, they're going to be dehydrated, ketoacidosis. They're going to have a low insulin level when you test their insulin compared to their blood glucose. You can test for this insulin-like growth factor and C-peptide as well, and then they're going to have ketones in their urine because they're breaking down the fatty acids. So they're going to have ketones, and their ketones are going to spill into their urine. So they'll have ketones in the urine, and you will test for this. Usually the treatment is insulin as a continuous drip that's weaned over months. It takes a long time to get these kids stable. They need a high-calorie diet, and then they'll need exogenous insulin for the rest of their life. But it's manageable. It usually takes a while to kind of like get them stabilized enough so you can like just do like regular sub-Q insulin, and I think is what that kid ended up going home on. So it takes a little while. Obviously, you'd have pediatric endocrinologists and a geneticist probably involved in the baby's management too, because we don't know everything. Okay, we talked about that already, so let's skip over. Now we're going to talk about kind of the opposite, which is congenital hyperinsulinemia. So we didn't have enough insulin, now we have too much. Most frequent cause of persistent severe hypoglycemia in the newborn. I feel like we had a kid with this too, actually, at some point. Incidence can vary 1 to 30,000 to 1 to 50,000. Can be autosomal recessive or dominant. Hypoglycemia can be transient. So if this kid's just septic, perinatal asphyxiation, infant of a diabetic mother, if you look at what their diagnosis code is, it's hyperinsulinemia. That's what's going on. So it can be transient, but it can also be congenital and be kind of a permanent state. If they're having a lot of respiratory distress, they're IUGR, they're premature. I put normal glucose utilization up there just if you're curious. 4 to 6 milligrams per kilo per minute for term infants, 6 to 8 for preterm infants. These kids require probably as much as like 12 to 14, maybe even higher. And these are the kids that like have unrelenting refractory hypoglycemia. Like they just like, it doesn't matter. D10, no. 12 and a half, meh, no. Put it at UVC, D15, no. D20, no. D25. D25, 250 mils per kilo per day, and your glucose utilization rate's like 16, and their sugar's, 42. And you're like, oh my God, seriously. It's annoying. Because it's like one of those admissions that like never ends, It's like the saga of the fluids. It's a real thing. And we kind of talked about the pathophysiology already. So you just have beta cell hyperfunction, or you have focal. So like you have some of your islet cells, and they're just hyperplastic for whatever reason, and so they're just like too much insulin, or spitting out too much insulin because they're hyperplastic. the thing that is scary about this is that because insulin decreases glucose and suppresses lipolysis and ketogenesis, so your body's ability to now burn glucose for energy in other ways, like with ketones or free fatty acids or protein, insulin, because you have such a load of that, suppresses that response. And so these kids are at high risk for neural development dysfunction, just because their cells won't function and then they die. So it's kind of one of those things. And they present shortly after birth. Like, these are not kids that, like, in 2 weeks you're like, I wonder why. Like, they're going to, like, right away. They're not going to have a good sugar ever for, like, hours. Differential diagnosis. So that Beckwith-Wiedemann I'm sure you've heard about. That's like an overgrowth syndrome, that they can have like severe hypoglycemia with that syndrome, and it is just an overgrowth syndrome. So everything is big. Their pancreas is big. Their hearts are big. Their tongues are big. Everything's macrosomic. So if they have a big pancreas, they're going to have too much insulin. And then the high umbilical artery catheter depends on what you have going in there. For a while, I was like, I don't get it. And then I was like, oh, some places will they'll split their amino acid vanilla bag, they'll run it through the UVC and their UAC, and then just to offer more trophamine to their patients, to offer more protein, the higher protein content earlier, like a nutrition, jump start. And so if you have a high umbilical catheter that's not in good placement, all it's doing is feeding that sugar to your pancreas, and your pancreas is like, oh my God, the sugar's 300, and like, here's all this insulin. So it made sense to me then. Thought I would share it with you, my little aha moment. Clinical features, these are going to be big babies. We talked about the persistent hypoglycemia. We kind of talked about all of this, actually. They're going to have low ketone body in their urine, though. So this is opposite, because they're not able, they have so much insulin that is suppressing that action of wanting to burn other things and burn their fatty acids to try to have an energy source for their cells. So they are not going to have any ketones in their urine. So that's just another way to kind of like really do like a solid differentiation between disease states. And there is the ketones present or absent. What is what right there for you, if you're curious. And then some of the labs that you'll do. And the biggest thing is just to remember to do the labs while your sugar is low. So you don't want to correct and then draw your labs. And so it's nice to know if you have a kid that's like having persistent hypoglycemia, to kind of like have in your head, like, what will I need for labs? What tubes will I need? It's specialty tubes that you'll have to get from downstairs, because you will not have time when your sugar is, unreadable and low on your glucometer to look everything up and call everybody. So it's kind of nice to like have a little, if you're like sort of moving in that direction, even if you don't ever get there, like you capture with D17.5, great. But if you don't, you're ready. So your kid isn't stalling for a long time with a low blood sugar. You know what you need, you can get your labs. And it's extensive. I think, didn't you draw labs with me last time we had it? And it was like, we draw these labs not more often than we diagnose with this congenital hyperinsulinemia for refractory. Brady loves to draw all these labs. It's his favorite thing, I think. So, but it's like 12 mils. It's a lot of blood. Maybe not, maybe 5. It just seems like a lot. Treatment is a high-calorie diet, a UVC for high dextrose concentrations, high GIRs, high fluid needs, and then we can treat with these different meds if we need to, if we get to that point. If it's a congenital, they can do a pancreectomy. They can take like 95% of your total pancreas, and you can still function with like just 5% of it. So they can take most of it, just not quite all of it. And multidisciplinary care with a pediatric endocrinologist is always a good idea. Okay, infants of diabetic mothers. Let's get down here. So, incidence of gestational diabetes, 3 to 25% of pregnancies. I feel like if you really wanted to make probably not make $1 million, but like if you really wanted to like make your mark on the neonatal maternal world, you would just like counsel moms about gestational diabetes, because I feel like they don't get enough of it in their clinics during their pregnancies. It's like such a real deal. We've all tried to feed these babies. There's so many problems. And I think moms just don't have a grasp on like the detrimental effects that it can have on their infants as high glucose loads, and like how to manage them effectively, and like what it means. It's going to mean like hard life choices. Soapbox, I'm done. Maternal resistance to insulin results in an increase in infant insulin secretion. And then you have that cord cut and you have this hyperinsulinemic state and you have these big macrosomic babies, you have high rates of fetal growth, you have deposition of fat, enlargement of all their internal organs. There's lots of things that happen because of all of this insulin that they've constantly been secreting while they're inside, because they have this high glucose level. They're constantly exposed to glucose, rapidly diffuses, and then their body is just like all the insulin all the time. Fetal hyperinsulinemia drives catabolism, which is just a breakdown of any molecular substance for energy. Just to like define that word. So you have increased energy use, you have a depleting fetal oxygen stores. And actually I'm going to switch to the other screen because I think it looks better like this. So you have macrosomia for complications for infants of diabetic mothers. So you can have lots of heart problems, lots of septal hypertrophy, cardiomegaly, LGA, birth trauma because they're so big. Kind of getting out is a problem. Lots of C-sections for these babies because they're so macrosomic. Hypoglycemia, obviously, they can be hypocalcemic and hypomagnesiemic. Relative hypoxemia, so you have this big tissue, this big baby with all this tissue, and you need to perfuse this tissue, right? So you need all these red blood cells to perfuse this tissue. So they come out and they're like polycythemic because they have just this massive red blood cell load. So then what happens? You have thick blood, so you have this hyperviscosity because you have all these red blood cells to try to perfuse all of this darn tissue and all of these huge organs. So you're at risk for renal vein thrombosis and even thrombosis in other areas of the body. And then you have all these red blood cells. What's going to happen in like 60 or 90 days? They're gonna die, and then you have all this bilirubin that now you have to control their hyperbilirubinemia. So that's kind of the problem with that. As you know, they can have respiratory distress, and this is, and I read in a book somewhere at one point that it's the insulin that just has an effect on like surfactant production, which is kind of why they can have all their respiratory distress. Not to mention the fact that they're just trying to move this chest that's enormous with these lungs that aren't functioning, and these kids are often delivered a couple weeks early. Yes, friend?
The hyperinsulinemia state suppresses surfactant production of baby.
Yes. Yeah. And then these congenital anomalies down here, caudal, which I have a picture of this caudal agenesis, I think on the next slide or somewhere down here. They can have neural tube defects, small left colon syndrome, and a VSD, which is another cardiac defect they can have too, some congenital defects. This is a picture of caudal regression, and it's ugly. So sometimes you can have caudal agenesis where they have no legs, or you can just have caudal regression where their legs are just kind of shrivelly and not functioning and they'll never walk or anything like that. I mean, that's severe. You don't see that all the time, obviously. But like feeding problems too, which is not even really on these slides. I mean, these kids are terrible eaters. I think there's like tons of literature coming out about that, but it can be a big problem. So you guys know what you do to diagnose this. You do their blood glucose, you do their electrolytes, we'll do an H&H because they're so polycythemic, see what their crit is, echocardiograms, x-rays. You just want to keep them in a euglycemic state, so you want them to be in a normal state. Whatever that takes, whatever their tissue and their metabolic demand is, you meet it, and then you gradually try to take it away as their body can like decrease that insulin production. UVC for GIR infusions if you need like a high dextrose concentration. And then early feedings, so usually feedings will stabilize their blood glucose a lot better than IV glucose. So if you can get them feeding early, that's helpful. And morbidities are associated with the neurologic sequelae, developmental delays. Sometimes these kids have behavioral differences. They're set up for obesity and diabetes problems for the rest of their life. So they are screened a little bit closer with their pediatricians if they have if they're an infant of a diabetic mother, their chances of having diabetes later on in life as a school-age child is increased. So, and then mortality related to birth trauma, and then their congenital defects usually, not the insulin itself usually, but the cause of it. Okay, this is the end-ish. Like metabolic disorders are at the very end. So we're on the tail end. You guys are just like hanging in there. You're doing so good. Like boring you to tears, I feel like. Calcium homeostasis. We'll talk about calcium, we'll talk about magnesium. little bit. We'll talk about phosphorus. We'll talk about osteopenia of prematurity. I think that's it. So a normal calcium range is about 8.5 to 10.2. Kids will have a natural decline in calcium after they're born, and it's not uncommon to find a term baby with a calcium of 7 on that their first labs, or 7.5. It's okay as long as it's in the first 12 to 24 hour, 48 hours of life. They'll kind of start to creep back up. You want to see a trend. Ionized calcium, which is your free ionized calcium, which is the bioavailable form of calcium, or like the active component of calcium, and that range is 1.1 to 1.36. And if you have it, usually you get a total calcium and it's low, you'll usually send for an ionized calcium just to see what your ionized is, because that's really what your body can use for the calcium that it needs. Surprise, surprise, it's regulated by a parathyroid renal hormonal axis, so it's got like a cascade of events that then turns it off at some point. Functions, calcium maintains, does all these really important things like maintaining cell membrane permeability so things can get in and out of the cell as it needs to, muscle contractions, nerve transmission, blood clotting, normal cardiac function, and then obviously your development of your skeletal system and the health and integrity of your bones, your skeletal system. Serum calcium, just to remind you, 40% of it is protein bound, and then you have about 10% that's inactivated, and then you have about 50%, which is your free bioavailable calcium. Calcium is regulated by all of these substances here. Your parathyroid hormone, that is those little parathyroid glands. They sit on your thyroid, those little 4 on the little butterfly phalanges of it, kind of. Increase your serum calcium by mobilizing calcium from the bone. So when your calcium level drops, it mobilizes it from your bone. Hey, we need some more calcium from the bone. Osteoblasts go to work and get the bone. Get the calcium from the bone, just like that. Reduces renal excretion, so it can tell your body to reabsorb calcium down there in your kidneys. And then it's stimulated, your parathyroid hormone is stimulated by low calcium and magnesium. And it's suppressed then by high calcium or high magnesium. So calcium and magnesium work together. Calcium and phosphorus work inversely. They're kind of inversely related. So we'll talk a little bit more about that, but just to kind of give you a hint. Vitamin D works with parathyroid hormone and increases the absorption of calcium and phos from the intestines and from the bone. This 1,25-OH2D3 is actually a hormone, and we'll talk a little bit more about this in a minute, and it's the biologically active form of vitamin D. Calcitonin lowers your calcium by inhibiting bone reabsorption, and then phosphorus inhibits absorption of calcium, and like I said, it's inversely related to calcium. So if you have a high phos, you're going to have a low calcium, vice versa. You have a high calcium, you're going to have a low phos. You kind of want them balanced within this ratio. Like everything, right? Balanced. So just to give you a reminder, vitamin D is made up of 2 components. You have vitamin D2 and vitamin D3. Vitamin D2 is your plant-derived vitamin. And then D2 is called the ergocalciferol, and then D3, which is what we give our babies, is that cholecalciferol. And that's synthesized in our skin from the sun. So we're just getting a synthetic form of it. Both of those, D2 and D3, they go through this hydrolyzation process in the liver, and then they form to form like a circulating form of vitamin D, and it's there right next to the liver, and it's 25-hydroxylase. So it kind of goes through this process in the liver, and it comes out as 25-hydroxylase. And then the 25-OHD is then hydrolyzed again in the kidney to an active form of 1,25-OH2D3, also known as calcitriol. And that's the one that makes a difference. That's what helps the calcium reabsorb in your gut. And so it has to kind of go through a couple different events to like get to the form that is actually useful in your body. So if we want to test a baby to see if we're giving enough vitamin D, we'll often send for this 125-OH2D3 lab. We're not just going to send for like a vitamin D level. So that's why, if you've ever had to draw a vitamin D level, that's what you'll be drawing. And it's just a hormone, and it's required for the parathyroid gland to work, parathyroid hormone to work. And then in your GI tract, it just improves calcium and phosphorus reabsorption. Just a few things more about calcium homeostasis. Acidosis will increase calcium. Your alkalosis state will kind of decrease the level. We talked about the inverse relationship between phosphorus and calcium. So phosphorus will inhibit absorption of calcium, and then that will switch. And a normal magnesium level is mandatory. So if you're having trouble getting your baby's calcium level up, and you're giving calcium, you're giving, calcium bicarbonate orally. We haven't ever really done that here, but in other places, they're these chronic long-term babies, super poor nutrition, just cannot get their calcium levels normal. Sometimes it's helpful to check a mag, and if you have a low mag, if you correct your mag, sometimes your calcium will correct itself. So just a pearl. Hypoglycemia or calcemia, so you have a serum less than 7 or an ionized less than 1. That's just a 1.01, sorry. The differential on that is there is some genetic congenital forms of it. There is a syndrome called DeGeorge syndrome that's got some cardiac abnormalities, some abnormal facies, like a cleft palate, thymic hypoplasia, and then parathyroid gland agenesis. So they have low calcium. Low calcium and kind of truncal heart defects, like those two things combined in a baby, you might want to think about DeGeorge syndrome. They're kind of two things that go hand in hand. Prematurity, just because they're little. Calcium is accreted or stored in the last couple weeks of pregnancy, couple months of pregnancy. So all of our preterm babies, including our late preterm babies, don't get enough calcium from their moms. So you accrete later on in your gestational age, which is why we send kids home on breast milk with 2 bottles of formula a day, because they have that formula. Preterm formula I have a slide in here that kind of shows it has lots of calcium, phos, magnesium, all their minerals that they need that they didn't accrete from mom. And it will take them a while to build up those stores from taking it in themselves. Everything works better on the inside, right? When they're on the inside with mom, they accrete them at a faster rate than they can on the outside. So usually some pediatricians will say, well, how long do they need to be on that formula for? And it's like 6 months to a year, really. They should, depending on kind of what their levels are. But it takes them a long time to accrete those minerals into their bone and kind of have good stores for when they need it, when they're trying to do it on the outside versus from the inside. Placental insufficiency can cause a hypocalcemic state in babies, or like a high phosphate formula. Maternal hypocalcemia, obviously, if you've got perinatal asphyxia or stress, like lots of our cooling kids will have super low calciums in the very beginning, and they will need replacement usually because nothing's working. If they have an exchange transfusion, you can have low calcium. Sometimes lipids can interfere a little bit. And then alkalosis we talked about, or chronic diuretic use is a really big one, especially in our term kids. And those urinary losses with that chronic diuretic use, the calcium just flows on out. So you're giving all this vitamin D, you're fortifying their formula, and then you're giving your aldactazide all the time, or you're giving your Lasix, bursts here and there for wet lungs or whatever, and then you're just shooting yourself in the foot. But we do it all the time. It's like a give and take. We talked about where the parathyroid glands are, and impaired parathyroid hormone leads to hypocalcemia. Just another little chart if you like charts. Clinical features of hypocalcemia. The biggest one is the tetany down there. So jitteriness, seizures, a high-pitched cry, stridor. They can have some EKG changes if it's really severe. Poor feeding, apnea, prolonged bleeding, because it has to do with clotting time. Something about all the things that calcium helps you do. And then when you don't have enough of it, this is what you see. Poor perfusion, tachycardia, hypotension. And then when we treat it with calcium gluconate, not calcium chloride, calcium gluconate. I think that's so funny that how many years did we go with those emergency med sheets and not catch that? Side note. You usually use 10%, and you do 2 mils per kilo, and you do it really slow. If you have a central line, it's best because it can be really, really toxic to your skin. So give it slow. Just hang out and watch your IV if you have to give it peripherally. because it will eat your tissue up to the bone if it infiltrates. So, and we can give enteral calcium. It just takes a lot longer if it's like a pretty significantly low. It's better to just give them a dose of calcium gluconate and then start with some enteral supplementation if you need it afterwards to kind of keep it up. This is a lot of words, so we're just going to skip this. You can go back and look at it if you want to. It's from this Avery's Book of Neonatology. I like this next slide a lot. Preventing hypocalcemia. So current recommendations for preterm infants is 150 to 210 milligrams per kilo per day of calcium. And there's your calcium to phos ratio that we kind of try to keep when we like write TPN. You kind of try to keep that calcium phos ratio, and then it kind of just naturally happens. Like in your preterm formulas, they kind of try to keep that ratio as well. And then your recommended vitamin D varies a lot institutionally. There's lots of literature on like high doses of vitamin D. Some people just do 200 IUs a day. But the AAP recommendation is kind of the median there is in red, 175. Your peripheral TPN, what usually you'll give like a vanilla TPN. So that's nothing, right, compared to what they really need. Central TPN, so something that you can actually write, that you can like add more additives, that you have a little bit of flexibility, because as you add things to your TPN, you increase its osmolarity, right? And you can't increase your osmolarity very much if it's not a central TPN. If it's peripheral, you're super limited on like what you can give because it can't be too caustic to that vein. And then preterm formula at 24 cals per ounce gives 150 mils per kilo per day, gives you 200 milligrams per kilo per day of calcium, which is awesome. And then fortified human milk gives you about 177, so kind of right in that median for AAP recommendations. And then unfortified human milk only gives you 42 milligrams per kilo per day. So, I mean, you're not going to keep all these numbers in your head, but I think that, like, how many times do we come across that mom who, like, wants to breastfeed exclusively, she's not super wild about formula, she's got a 34-weeker, 33-weeker, and baby's pretty good size, and, like, she just wants to breastfeed and take that kid home. Like, really, she needs a lot of teaching about, like, why do we want to fortify her milk? Well, what's wrong with my milk? I mean, I think we just get that all the time, you know, like, what's so important about calcium? What's so important about phosphorus? You know, your baby didn't get a chance to gain it from you because they came out so early, so you've got to give them back those stores, and your milk just doesn't have enough because it's not designed for a preterm baby in that way with that mineral. You know, they gain that from being inside of you across the placenta, not from your breast milk. So kind of a nice talking point for parents if you can kind of keep it in the back of your head. Metabolic bone disease, we see this all the time. It used to be called rickets. We don't really call it rickets anymore. It's osteopenia, prematurity, metabolic bone disease. All those terms are interchangeable. 30% of our very low birth weight infants, 50% of our extremely low birth weight infants, probably more than that, honestly. And this is a good statistic, 80%, there you go, of calcium and phos are built in the bones of the infant in the third trimester. And all of our kids are missing that. All of our low birth weight, very low, extremely low birth weight kids are missing that third trimester. Poor mineralization postnatally, so it just doesn't mineralize or accrete in their bones like it should. And we delay their enteral feedings. You know, we don't feed right away. We're not really good about feeding right away here. And sometimes we can't if they're not stable enough. If they're on long-term TPN, if they're septic, if they've got bronchopulmonary dysplasia, they've got some cerebral pathology or neuromuscular conditions that leads to like a prolonged immobilization. They've got acidosis attacks, if they had a bout with neck, cholestasis. And that cholestasis comes into play more because they just can't absorb the vitamin D then. So it can't help with the absorption of the calcium. Use of diuretics like we talked about, steroids, and then caffeine too can affect it a little bit. But caffeine has so many other positive effects that we would never take away that just because it might affect their bones a little bit. It's like the miracle drug of NICU, like surfactant, caffeine. It's like they're equal. We use a marker, serum alkaline phosphatase, to, I don't know why, that's the wrong abbreviation, sorry about that, you guys, to mark for osteopenia. And we like to compare that to like what their FOS level is. So normal preterm FOS would be somewhere between 4 and 8. 6 is great, 7's even better. 8 would be like really great. You get gold star for the day. It's a glycoprotein. It's found in the bone, liver, kidney, and intestines. So it's not just specific to your bones, but we do use it into the marker because mostly when you have bone degradation, you have this elevated alkaline phosphatase. It originates in the liver and the bone. It can be elevated with normal growth sometimes or liver disease. And it's an indicator of just how much has accumulated in the osteoblasts as it like degrades that bone and gets rid of that bone as it tries to like get the calcium out of the bone that's probably not really there to begin with. So you have these thin, frail bones that are not very strong, that don't support your respiratory system. So on top of your chronic lung disease and your parenchyma in your lungs that doesn't work well anyways, then you have these ribs and this sternum and this vertebral column that doesn't really help you breathe at all anyways because your bones are crappy. And then you have to sit in a swing and you really can't breathe, so it's like a whole saga of events. Best used this marker as a trend and then in conjunction with what your FOS level is and then radiologic findings. And then when I traditionally have learned about and talked about metabolic bone disease, you look at lung x-rays, but the actual x-ray that you technically should look at if you're going to diagnose it is this cupping or widening of the metaphyses in your knees. So you can see on the grade 2 one what such a loss of that demarcated white line. So like kind of the end of their bone just starts fraying and looking really like yucky. Sometimes they can have skull fractures, or they can have rib fractures. They can have like a femur fracture, or they can have a scapula or clavicle fracture, like you see an old fracture. I feel like a lot of our kids, not a lot of our kids, but like kids that you hear about having fractures, it's like their humerus will have like a healing fracture where you're like all of a sudden like, what the heck? Like, where'd that come from? You never really even know it was there. It's just like a healing fracture just because their bones have been so, weak. They can have some frontal bossing, decreased linear growth, craniotaves, which is like, it's like you push on their skull and it's like that. It's like this kind of a feeling, like you would be pushing on a can, so their bone is just like so thin, it just kind of like goes in and out. Never felt it, don't want to feel it. Yuck. But it's a thing. And then poor compliance with their respiratory distress is not helping them at all. And prevention is key, so we try to treat with vitamin D. We try to offer like good fortified formulas and breast milk and try to get ahead of the game before we're behind. And there's a good a good AP chest film that just shows that, horrific lung disease, right? That's what you see there, yuck. And then all those little like fluffy little like blebs and a little bit of PIE there. And then just the thinning, like how thin the ribs look. They're just like almost transparent in places. And on the flip side, hypercalcemia, not seen as much at all. Usually it's because we overtreated, which it's really hard to do that. So we don't hardly ever see this. Sometimes if they have subcutaneous fat necrosis with like, if you have a cooling kid that then has like subcutaneous fat necrosis, which is like a calcium buildup, it kind of looks like a little nodule under their skin. As those break down, you will have a little bit of like hypercalcemia. I've never seen that, but I'm sure it has happened, and it says so in the literature, so I'm sure somewhere it has. There is a familial infant hypercalcemia that is around. That could be a possibility if your kid has this. So they have CNS effects like hypotonia, weakness, irritability, poor feeding, bradycardia, constipation, vomiting, polyuria. Usually you can treat by dilution, so you usually offer a volume expansion, and then you can also Lasix to try to get them to pee off some of that calcium. Nephrocalcinosis is a complication, and that's even a complication with our kids that are receiving calcium supplementation along with Lasix, because or aldactoside, even to any diuretic, which offers them the chance to pee off more fluid, and as you pee off more fluid, you have more calcium going through those kidneys, and sometimes we get these little calcium deposits built up. They can have bradycardia, or they can have even some like calcium deposits if their calcium's too high in their brain. Not seen very often. Just some more pathophysiology on neonatal hypercalcemia. Kind of the workup and the management if you're more interested in that. Okay, we are literally almost done. I have just a couple more slides. I know it's 6:30. We started just a teeny bit late, so we're just going to finish really quick. Phosphorus, 80% is found in bones. It's like almost more important than calcium for like all the things that it does. Cellular function, energy stores. Peak accretion is late, 36 to 38 weeks. So all of our preterm babies are deficient in phosphorus and need it probably way sooner than we offer it. You can see where it's absorbed there, filtered and absorbed by the kidneys. Normal levels 4 to 8 like we talked about. And then kind of what you need to meet normal demands for your term and your preterm babies. And this is best absorbed intrally. So we're like behind the 8 ball from the very beginning. And then, I mean, you think we're going to be able to give intrally for 60 to 140 milligrams per kilo per day of phos? No, there's no way. They're not eating, they're puking green. It's really hard to catch back up with phos. So we do the best we can. Magnesium, second most common intracellular electrolyte after potassium that we talked about. So magnesium, potassium like to be inside the cell. Fourth most abundant mineral in the body. It is the catalyst for intracellular enzyme reactions like muscle contraction, carbohydrate metabolism, normal parathyroid function. It works with calcium, remember, so bone, serum, calcium homeostasis, regulated by the kidneys. Normals like 1.5 to 2.5. Hypomagnesemia suppresses the synthesis and release of parathyroid hormone. So if they're low in magnesium, it suppresses that release of PTH, so your calcium is going to fall. So that's where the key comes in often. If you're struggling with your calcium, if you just maintain your mag, naturally it won't kick in your parathyroid hormone to then give you more calcium. So they work together. And accretion, again, takes place in the 3rd trimester, so all of our preterm babies miss out again. Less than 1.5 for low. Hypermagnesemia, really we see that with what our kids, who do we see more mag in? Our kids that come from preeclamptic moms, who moms were on mag and now they've got this huge mag load. Greater than 2.5, excess infusion or maternal infusion. They can have decreased renal excretion for renal failure, oliguria, poor gut mobility. So often if their mag's like 5, something ridiculous, 4, we'll kind of try to like not feed them until they either stool or their mag level starts to drop a little bit because they just won't, it'll just sit there, their gut's not moving at all. You guys know all of the signs and symptoms of hypermagnesemia. How often do you go down the kids that's on mag and just comes out like totally magged out? Respiratory depression, lethargy, poor suck, flaccicity, hypotonia, not good for breathing, sometimes abdominal distension. Hypomagnesemia, if we don't give enough mag, a lot of times the other population that we see it in is like our kids after GI surgery. So I don't think this unit sees it a lot, but like children's unit sees it a lot where they have their short gut kids or their bowel resection babies, where they don't have enough time to absorb their mag because everything's just dumping through because they have such short guts. So that's another place that you have struggle with low mag levels. If you're in renal failure, you struggle with low mag levels. Tremors, irritability, seizures. Kind of the difference between those two. Okay, just have some questions and then we're done. If you don't know the answer, it's fine. Symptoms of hypoglycemia do not include which of the following? If you think you know it and want to be brave, just shout it out. If you're wrong, I'll get slapped. Kidding. Keyword does not include hypoglycemia. So do you see tachypnea if you're hypoglycemic? Think about the kid that comes down from newborn. They're hypoglycemic. They get to you and they're cold and they're apneic. And now they're breathing fast. Do they have diarrhea? No diarrhea. But all the other ones, yeah. Like they're broken. They had low blood sugar and now they're broken. Or they're fixed sometimes, but sometimes they're broken. Parathyroid hormone does which of the following? Mobilizes calcium and phos from the bone, increases urinary calcium excretion, inhibits calcium mobilization from bone, required for vitamin D to work. What do you think? kind of a hard one. Ish. A. I'll just give it to you. Mobilizes calcium and phosphorus in the bone. It's for calcium as well. Your parathyroid hormone kicks in and says, hey, osteoblasts, we need to reabsorb the bone. We need some more calcium. Go chew it up because we need that calcium in there. Adrenal insufficiency in the very low birth weight infant does not result in which of the following? Tachycardia, decreased urine output, hypernatremia, hyperkalemia. It always helps me when I think about the baby. So I think about like a preterm baby, like a little 700 grammer. We've got like hypotension. We're on 20 mg of dopamine. We're still having hypotension. We're not peeing. We've got tachycardia, probably because we're on 20 mg of dopamine. C. Good job. Hypernatremia. They have low hyponatremia, hyperkalemia. Which of the following is true regarding transient hypothyroidism of prematurity? Or, I didn't name it this, but in the literature, it will call it hypothyroxemia of prematurity. So which one of the following is true regarding this state? It is associated with a high TSH level, is treated with PTU, which is that medication that we kind of talked about briefly, and I wouldn't pronounce for you, is associated with a normal TSH level, longer duration in less mature infants. This is kind of a tricky one because it could almost be two. Sorry about that. It's a transient state. What did you say? Did you say C? C. Yeah. It's a transient state, so it's usually associated with a normal TSH level. It's usually not till it's significant that your TSH kicks in. It's just a low free T4. It's okay. It's just kind of low. But the TSH is like fairly normal, whatever that means for that preterm baby that's 700 grams. We don't really know. Yeah. All done. And then I have all the references if you're curious. Thanks, you guys, for being a fantastic audience.